How to care for a sick patient, whether that's an adult or a child. So for an adult sick visit, this is kind of the template that you can follow. Um, it just kind of asks, like, when did your symptoms first start? You know, do they have a fever, postnasal drip, sore throat, sinus congestion or pressure in their face, a cough, whether that's includes wheezing or shortness of breath, or if it's dry or productive, headache, ear pain, vomiting or diarrhea, a skin rash, any medicines they've tried, whether or not they're over the counter or a prescription, if they're a smoker, and any sort of sick exposure, whether that's to strep throat, COVID, or other individuals in the household that they live with. And then you want to make sure that you review, of course, their vital signs, including their temperature, to see if they have any fever at all. And then your assessment is going to include looking in their ears, their nose, their throat, checking their neck for any enlarged lymph nodes, listening to the lungs and their heart and their abdomen. And then for the pediatric patient, it's kind of similar, except they're accompanied by a family member, whether it's their mother or their father or brother, sister, etc. Again, the symptoms when they first started, if they've had fever, postnasal drip, sore throat, sinus congestion or pressure, cough, headache, ear pain, vomiting or diarrhea, skin rash, any medicines that they've tried over the counter or otherwise, and any sick exposure. The assessment is also as follows: looking in their ears, their nose, their throat, feeling their neck, listening to their lungs, their heart sounds, and their abdomen. So if you have an adult who has a sinus infection, you suspect a sinus infection, that includes symptoms that they've been sick for over 7 days. Typically they have sinus pain in their maxillary sinuses or their frontal sinuses, and they have green or yellow mucus that they blow from their nose, or they're coughing up out of their throat. You can prescribe medications that include Augmentin, Levaquin, clindamycin plus Omnicef, or doxycycline. Usually we reserve Levaquin for patients who have a lot of allergies that don't allow us to prescribe the common medications. I typically prescribe Augmentin and doxycycline most frequently to patients for sinus infections. For ear infections as an adult, it's not very common, but we do see this sometimes. Lots of medicines to choose from, whether it's amoxicillin, Augmentin, Omnicef, azithromycin, clarithromycin, or doxycycline. Lots of choices, again, depending upon their allergy list. And if you're trying to treat concurrent symptoms, so say you suspect a sinus infection as well as an ear infection, you can pick Augmentin, for example, and treat both. For strep throat in adults, you can choose amoxicillin, Keflex, azithromycin, clarithromycin, or clindamycin. You want to make sure you swab them or have your roomer or swab their throats. The rapid test through the machine is about 99% accurate for strep A. Otherwise, the strep culture takes a couple of days to come back. And it doesn't mean that everyone who does not look like they have, white patches in their throat and all of those things don't necessarily have strep throat. I've seen all sorts of cases in which their throats don't look that bad and they have a positive strep A. And then I've seen other cases where their throat looks horrible and you 100% are certain that they have strep throat and it comes back negative. So a lot of times you can't trust necessarily what you're seeing on exam. For patients with recurrent ear infections, if you gave them amoxicillin to begin with, you can always treat them with Augmentin as the second choice. If you already treated with Augmentin, you can choose other options like Ceftonir, Ceftin, or even Levaquin. Again, Levaquin is usually used as a last resort if the other medications aren't working or they have allergies that limit that. Now, if the patient's been initially treated with a macrolide or clindamycin, you can, of course, give Levaquin. Again, it's based upon how they're presenting. Always, if they have recurrent otitis media, you certainly want them to come into the clinic so you can actually check that out and see if they really do have that, or if it's just fluid in the middle ear. A lot of times, after they have an ear infection that clears, sometimes they have lingering hearing loss, or lingering ear pain because of fluid in their ears. A lot of times Flonase or taking Zyrtec over the counter for about a week or so resolves those symptoms. Zyrtec would be about 10 milligrams once daily, and then Flonase can be 1 to 2 sprays each nostril once daily to treat those concerns. So sometimes that's a simple fix for those patients. For recurrent strep throat, if you gave them penicillin as a first choice, whether that was amoxicillin or even Augmentin, sometimes you can then give Keflex as a secondary option if their strep throat isn't gone. Again, you want them to come to the clinic, repeat a rapid strep to confirm that they still have strep throat. If you did give them Keflex as the initial therapy, then you can choose Cefdinir or Omnicef as your secondary choice to see if that helps. Otherwise, you can always give them clindamycin. There are some patients who are just strep carriers, and they will complain about a sore throat and always be strep A positive, even if they do not have tonsils. I've seen this a lot where even if they don't have tonsils, they can be carriers of strep A, which is interesting. If they do complain about a sore throat, you can give them clindamycin or Augmentin to see if that clears it up. You can always send a referral to ears, nose, and throat and have them work these patients up further. Some cases require tonsillectomy if they have recurrent strep throat and they've been on chronic antibiotics. You definitely want them to be evaluated further to see if there's other solutions to this problem. Now, for community-acquired pneumonia, if they are otherwise healthy patients and they haven't been on any antibacterial medications in 3 months, you can certainly give them azithromycin or a Z-Pak that's used most frequently for these types of patients. Otherwise, we do doxycycline 100 milligrams twice daily for 10 days to clear up those problems. Otherwise, if they have comorbidities like chronic heart, lung, liver, or renal disease, diabetes, alcoholism, immunosuppressive medications that are on board, or they've used other antimicrobials in the past 3 months, you want to consider more medications that could treat this, like a Levaquin, for example, that would take care of the problem. Or you can give the other medications listed below. Typically, patients receive Omnicef and doxycycline given together. That's usually what is prescribed. You'll see this a lot in the ER. Omnicef would be 300 milligrams twice daily for a total of 10 days. Doxycycline is 100 milligrams twice daily for a total of 10 days. So these are other choices that certainly you can pick from when patients are coming in with pneumonia, and you want to make sure that you do a chest x-ray to kind of confirm this sort of thing. There are some patients who have COPD and a COPD exacerbation. A lot of times, if they do have that problem, we would treat them like they have a pneumonia, as well as giving them a steroid. So a lot of times I'll choose azithromycin or a Z-Pak, or you can give doxycycline. Again, 100 milligrams twice daily for 10 days. And then also you'd want to give prednisone, a burst of prednisone, not the medrol dose pack because that's not enough. Prednisone would be 40 milligrams once daily for a total of 5 days to see if that could clear up the problem. Again, close follow-up if they're not feeling like they're improving or getting better. You can always consider a chest x-ray for those COPD patients as well. And you want to educate them if they're having difficulties breathing, they should go to the ER for further workup of that.